As we all know, modern cataract surgery is safe and patients expect to be spectacle-free postoperatively. As we will heard in this symposium, we have advanced phaco technology, laser cataract surgery, refinements in surgical techniques, and premium IOL. But the first step to optimizing visual outcomes is accurate biometry. We need to have accurate measurements of the axial length, the corneal powers, the AC depths to have good visual outcomes. And these attributes to 22 to 42% of IOL refractive error respectively. Ultrasound biometry used to be the gold standard for biometry, and then the optical biometers were introduced. These instruments are non-contact, less user-dependent, easier and quicker to use, reducing the risk of infection with increased patient comfort. Most importantly, it gives rise to increased precision, and as shown on the line in red, it gives the true visual axis. It measures the true visual axis. However, there is still a role for ultrasound biometers in case for dense cataracts and posterior subcapsular cataracts where the light beam is unable to reach the retina for the PCIs and the LCORs. The IOL Master was developed by Carl Zeiss in 1999, making use of the principle of partial coherence interferometry in a dual beam configuration powered by a multimode laser diode. The axial length is measured from the anterior corneal vertex to the RPE versus to the internal limiting membrane for the ultrasound biometry, and as a result is around 0.15 millimeters longer. Keratometers are built in, and the K readings are measured by analyzing the anterior corneal curvature at 6 reference points in a hexagonal pattern at the 2.3 millimeter optical zone. AC depth is measured by lateral slit illumination, defined as the measurement between the corneal epithelium and the anterior lens surface. It has a high resolution down to 10 microns versus 100 micron for the ultrasound biometer. In the pre-IOL Master era, the axial length used to be the largest source of error, but after the IOL Master was introduced, the AC depth became the largest source of error. In the Asian population with a high prevalence of myopia, sometimes with posterior staphylomas, the PCI is especially useful. The latest model is the IOL Master 500, where consecutive scans are processed into a composite signal with improved signal-to-voice ratio in eyes with low signal amplitudes, making it easier to scan posterior subcapsular cataracts. The dual mode, the axial length and keratometer in one measurements, making measurements faster. As mentioned, because the axial length is measured to the RPE, whereas the A constants provided by the manufacturers are ultrasound derived, it would lead to a hyperopic surprise, and as a result, we need optimized A constants, and the user group for laser interference biometry website provides a good reference starting point for these optimized A constants. However, it must be noted that these are neither verified, validated, or confirmed. Just an interesting point from the ULIB website. For patients with extreme myopia, even though we have the IOL Master allowing more accurate measurements of the axial length, we do still get hyperopic refractive surprise. The reason because the negative diopters intraocular lenses are concave in design, whereas the positive diopters intraocular lenses are convex in designs and are therefore theoretically two different types of intraocular lenses warranting different A constants. Back to the iometers. The Lenstar LS900 was more recently developed in 2008, making use of the principle of optical low coherence refractometry powered by a superluminance diode. A higher resolution can be achieved with the superluminance diode than the multimode laser diode, and as a result, the refractive structures within the cornea, the anterior chamber, the lens, and the retina can be displayed and measured. So besides the axial length, it can also measure the central corneal thickness, the AC depth, the lens thickness, and the retinal thickness. And the AC depth is defined as the measurement from the corneal endothelium to the anterior surface, which is called the AD as illustrated, where ACD is like the IOL Master from the corneal epithelium to the anterior lens surface. It also assesses the white-to-white, pupil size, pupil and visual axis decentration, and the corneal powers are acquired by analyzing 32 reference points at 2 concentric rings. Because there are more reference points, studies have shown that the readings, the values are comparable to manual keratometers, which is good for toric IOL planning. The speed of these optical biometers have been compared, and it was found that the fastest measurements was with the IOL Master 500, although we have to bear in mind that the LensStar LS900 acquires additional information, including the central corneal thickness and the retinal thickness. And the percentage of unsuccessful scans for both machines are roughly similar at around 6%. They use different methods for post-laser calculations of IOL powers, and studies have shown good correlations of the measurements of the AC depths, K readings, and axial lengths between the two instruments, although the LCORs give a slightly longer axial length, deeper AC depth, and a flatter K. This is probably related to the calibration with the ultrasound biometers, and which is more accurate is quite difficult to say, but it highlights a very important point, and that is whenever we're using a new instrument, we have to optimize the A constants for different IOLs. Besides state-of-the-art optical biometers, for accurate biometry we need proper instrument calibration, protocols to ensure that the procedures are carried out in a standardized format with measurements taken for both eyes for cross-checking and repeated if there are suspicious deviations from each other. And biometry is a highly skilled process and should only be performed by designated and highly trained professionals, should they be doctors, nurses, optometrists, or technicians. IOL power calculation formula should be chosen with respect to patient parameters, and needless to say, the IOL power has to be chosen with respect to the patient's needs. The two variable IOL formula, including the Hoffa-Q Holiday Wong SRKT, makes use of the thin lens optical principles, and none of them is perfect for all range of axial lengths. And the general principle is that the Hoffa-Q performs best for the shorter eyes, the Holiday Wong for the mid-range, and the SRKT for longer eyes. And the SRKT is a very, very good general formula. With the newer biometry machines, we can have use the newer IOL formulae, including the Haggis with 3 variables and the AC depth measurements obtained from the IOL Master. There are 3 constants in this formula to define the positions and the shape of the power prediction curve, and so theoretically the 3 constants can reduce systematic errors associated with the whole range of axial length. Then there's the Holiday 2 with 7 variables, and the OSINT, which uses the axial length, the K readings, the AC depths, and also the lens thickness. There is controversy as to which IOL formula is the best, but it is generally agreed that the A constant, the optimized A constants, are more important than the choice of the IOL formulae. Now, quality management based on indicators is very important in modern medicine, and for example, the Royal College Cataract Surgery Guidelines recommend the unit performs it to optimize or personalize A constants. And the NHS benchmark says that at least 85% of postoperative refractive results should be within 1 diopter of the target refraction. Now, I work in a hospital with around 40 ophthalmologists, and an audit is performed annually on a representative sample of around 25 to 30% on uncomplicated vehicles. Each year we analyze a lot of factors, including patient factors, biometry-related factors, and surgical factors. Each surgeon have their own style of practice, and they have their own surgically induced astigmatism, size of capsulorhexis, and their choice of intraocular lenses. Biometry is performed by different departments using different machines, and even if the machines are the same, the software versions may differ, and as a result, this makes analysis quite complicated. However, our aim is to refine the areas that are modifiable, and most importantly, that is whether there is any biometrist skill variations. This is especially important when we're using ultrasound biometry, which is more skill dependent, and also optimization of the A constants. So I'd like to share I'd like to spend the last minute or so sharing with you some of the interesting findings that we have over the years to illustrate the importance of a continuous audit and how the changes in clinical practice and the evolutions of intraocular lens have a significant impact on the target refraction. Back in 2007, we experienced a drop in the target refraction to below the benchmark with only 79%, and there was roughly around half a diopter of myopic shift. We looked at all the causes and found that it was not to be operator dependent. We did all the recalculations and found it not to be related to the use of various IOL formula. And the culprit was found that surgeons was moving from the MA30 to 60 intraocular lenses to using and other Alcon lens, the SA60 lenses. And the A constant had to be optimized. And after we did that, the next year in 2008, we got better results to 90% within 1 diopter of target. But before we were happy, the year afterwards, the results dropped again to 80% within 1 diopter of target. And worse still, this time we had half a diopter of hyperopic shift. So what actually happened? To cut the story short, there was a change in clinical practice with more surgeons removing viscoelastic from behind the intraocular lens at the end of the surgery compared to around 2 to 3 years ago. In another study, we analyzed the AC depth to the axial length ratio as measured by Visante ASOCT and found the ratio to be significantly larger with the practice of diligent viscoelastic removal at the end of the surgery. Retained viscoelastic, although not to the point of causing an IOP spike or capsular back distension syndrome, did have a effect on the refraction by affecting the effective lens position, and so the A constant was again refined, and we started to get better results. However, after we did all these, surgeons were already moving to another newer intraocular lens. We recognize our limitations in that we were unable to generate personalized A constants for each of our 40 surgeons, but it is generally agreed that optimizing A constants for each IOL model confers a greater advantage. Also, we have to note that because the A constants do not vary with the axial length, when we are during the audit, we have to ensure that the sample taken has a typical spread of axial length to reduce errors in optimization. In conclusion, biometry is one of the most important steps to optimizing refractive outcomes for patients undergoing cataract surgery. In the past decade, with advanced biometry machines, IOL manufacture, and IOL power formulae, we have had increased precision with IOL power calculations and improving the visual outcomes. It is important to note that, however, not every patient is within 1 diopter of target refraction after surgery, and therefore it is important to audit the visual outcomes and to identify possible sources of error, and customization of IOL constants can eliminate systematic errors which may be related to differences in the methods of measurements or suboptimal A constants provided by the manufacturer. The aim, of course, would be to increase the number of patients with good unaided vision after cataract surgery. Thank you.
Thank you very much, Victoria.